Hi, and thanks for joining me today for another MK Healthcare Business Consulting discussion. Very happy to present to you measuring productivity and setting objectives, which is the third in our series of topics on productivity. And I'm just going to go through some of the detail that we'll be talking about today. We're going to firstly talk about what is your plan. We're then going to talk about the model I've developed for counting and measuring what you do. We'll move on to what I call the doing of your practice, what you do in your practice on a day-to-day basis. Then the KPIs, the key performance indicators, which are a key part of measuring your productivity. Achieving your career objectives plan, which is a document that, again, we've developed over years that covers the areas of how you go about creating a plan. We talk quite a lot about referrers and the risks to a referrer of referring to you, but also the benefits of actually referring a patient to you. We'll then talk about reviewing progress, how you go about assessing whether you're making progress or not. And we'll finish up talking about initiative and levels of initiative. So measuring productivity and setting objectives. There's a quote from Aristotle which I think works very well from this. So it's, we are what we repeatedly do. Excellence is not an event, it's a habit. So how do we continue to be excellent? How do we make that something we always do, not just one-off activity, but something that we strive for all the time so that it becomes habit forming and then is relatively easily repeatable and consistently done by us to improve our productivity. So I've developed a model that might help with some of the understanding of this, and it's a pretty simple concept about making sure we count and measure what we do. It's a series of concentric circles, and the first circle covers the area of why. We need to understand performance with the desire to improve. That's why we're doing this, is why we're going about the notion of counting and measuring what we do so that we can understand performance and therefore have a regular desire to improve. The second circle talks about the what we do. And this is simply a matter of developing measures that meet the SMART objective paradigm. I'll go into the SMART objective paradigm in a moment to illustrate that further for you. The third area we need to do is to look about how we go about this. And we go about this by developing relevant KPIs that enable us to look at what our weekly, monthly, and quarterly measures are that we can then review. So that model may be helpful to you to understand conceptually why we're going about doing this. Just to illustrate the point a little bit further, this is about productivity, improving productivity. The measures of productivity which need to be specific, measurable, achievable, relevant, and time-bound. In other words, SMART objective measures. The measures will be collected via key performance indicators that enable you to observe and be motivated by the progress that you see. And we can use qualitative and quantitative measures as motivators, but really when it comes to performance, the qualitative ones need to be something that can be objectified in some way to make them easier to see if they're consistently performed. And the quantitative ones need to be binary, and I'll talk a little bit more about that in a moment. And really, the story I've got for you is around the CEO of the network I work for, the corporate network, a guy called Ralph, who really introduced the concept of KPIs to me, not just on a personal basis, on a practice basis, on a network basis, because he talked about watching the numbers, and by watching the numbers, you would see the numbers improve. In fact, watching the numbers was a motivator to get them to improve. We talked about how creating a KPI for practices in a network allowed us then to do the weekly assessment and therefore gave us the ability that I talked about to improve. During the practice, I've mentioned some of these things before. You need to be available. So therefore, if you want to build up your practice and you're only there on Tuesday morning and Friday afternoon, that limits the opportunity for patients to come and see you. So you need to make sure you've got good availability with evenings, with afternoons, sometimes with some weekend times that people have got easy availability. You can't then say, oh, I couldn't get an appointment with you. You were too booked up, or those times don't suit me to come in. Reliability. If patients know that you're going to be at the practice regularly, not always going off on sick leave or going off on holidays or going off on conference leave, you need to try and work these sorts of absences to no more than 4 to 6 weeks a year, because that gives you continuity with patients and they get to know, oh, Charlie is there every Monday, Wednesday, Friday afternoon. or Hudson's there every day of the week, which makes it easy to get an appointment. Productivity. What is your volume of patients? What's your revenue focus? And how are you developing your referrers? So referrers, again, is a topic, and we need to really concentrate when we talk about referrers on what are the benefits and risks for a referrer of sending somebody to see you. What service value are you providing? What appointment lead times do people have? Can they get in the same day? We'll often say at the start of a day, if your practice is completely busy, you go and say to the front desk, look, I can stay longer tonight. It's not in the diary, but if somebody rings up, I can see them at the end of my practice if that's what they want. Because a lot of people make impulse buying decisions these days, and you'll find that if you're able to meet that impulse buying decision, you're much more likely to build your practice successfully. Gold standards of service. Sounds like a pretty simple thing, but the reality is it's not a value that people place. Gold standards of service is basically a warm and sincere greeting of the patient, providing them a personalised service whether they're there. If it's hot or they're distressed in some way, getting them a drink, providing them with a blanket, turning the light off, whatever the case may be, to make sure they've got comfort in the consult. And then when you finish the consultation, to provide a fond and caring farewell with a summary of what's actually happened in the consultation. So it's like a closing statement of what you've identified today, what do they need to do to improve their condition, what exercises do they need to do, and when do they need to come back. Finally, your clinical and presentation, not just you yourself, but the practice in general, needs to be of a standard where people would have expectation. It doesn't need to be a shirt and tie, but it needs to be clean, appropriate wear. People don't take well to coming in and someone to be practicing in jeans and a t-shirt. I think you need to look at that as not only that, but also your personal hygiene with your facial hair if it's a man, or the type of makeup you're wearing as a woman, and certainly with ensuring that your clothes are neat and trim. Clinical presentation also comes down to how you actually present yourself, not just with the right clothing, but the right attitude or the right affect, with a happy contention for people, smiling at people with your head up, and making sure that you're creating every chance to be communicating with them as well as you can. Key performance indicators or measures of your success. What will they be for you? Well, I think an important one of those right from the outset is to work in an empowering environment. Are you working in a place where you're learning? Are you working in a place where you're being assisted, mentored, developed? Is there key education that's being done for you? Are you being given a chance to give input into what goes into that practice? Or are you asking for people's input into how the practice could perform better? That's an empowering work environment. Creating what we call SMART objectives. SMART being specific, measurable, achievable, realistic, and timely. I think if you portray each of the objectives you have with these measures in place, they'll be more specific to you. One of the issues people have is they make objectives that are either totally unachievable. A good example might be someone says, I want to run a marathon in 2 weeks' time. How much running are you doing at the moment? I haven't started my program yet. That is not, it's very specific, it's very measurable, but it's totally unrealistic and not achievable and not timely. So run the filter of SMART objectives over each of your objectives. Having a mentor is very important. Over my career, I can remember 3 or 4 people at various stages of my career were specific mentors to me. When I was a clinician, when I became involved in the management role, when I got into a business role, and when I was in a corporate role. Each of those people was very specific to the need that I had at the time. I sought them out, and most people are willing to be a mentor and happy to do that. It's a role that I willingly take up because I benefit from having mentors, and if I've got something to help other people with, I'm happy to be their mentor. Seek that person out. If you do get your mentor, make sure you have a mutual expectation about what you're going to achieve. That's very important so that you're both on the same page. And finally, to have great communication with all stakeholders, be it your patient, be it the reception staff, be it the owner of the practice. If it's you, have great relationships with those that refer to you. have great relationship with your suppliers, make sure people explore their networks, because all of these various areas are sources of patients. I know a physiotherapist that started to see a lot of medico-legal cases of patients, and he was very good in his rapport with the lawyers that wanted the reports, till ultimately the lawyers were then telling other patients they should see this fellow. So actually it was a commercial advantage for him by developing a relationship with the lawyers that he worked with. And so therefore communication with all those people was vitally important. So I've already talked about this a little bit, but just to reinforce it again, specific and measurable, easily accessed and produced. Achievable, not going to be built in a day. Relevant to you and your practice. Timely, do they measure, and those key time points we talked about, and binary, are they able to say, yes, I achieved it, or no, I didn't. The slide I'm showing you now with the KPIs on it is an excerpt from a KPI performance report that was for a network of 10 practices. You can see that these practices, the network of practices, generated fees of nearly $200,000 on the total revenue line, and that means that they were turning over roughly $10 million in that network. And I believe that was 13 or 14 practices at that time. So all we did was consolidate the results of the 12 to 13 practices into a sheet that we looked at on a weekly basis for the network, because that was what the corporate was interested in. But just as equally important, each practice got their own individual KPI for their particular practice, and the consolidated went to the more senior people. But rather than detail this too much, you can see that it's got the weeks of the year. The snapshot period relates to the average of the last 6 weeks of performance, which is a good chunk of time to see whether that's trending the right way. And then you'd have the year 46-week average as well. And you'd see you've got the totals of the revenues on the left, and the various totals in the weeks, and the snapshot and the average, and then the A.C.O target and whether it was achieved or not is in the brown. So therefore, don't go into the details, but you can see in this particular group of practices there are a number of services. I'm not quite sure where some of those other details were, because there were some practices that had very specific services such as nutrition and myotherapy. This is from some years ago, and the myotherapy was not a big component of the practice, whereas in the year 2000 many of these practices have myotherapy. But it is something that I'd like to see more widely involved in multidisciplinary practices is more services of myotherapy, because I think that's been a very vastly underutilised area in musculoskeletal practice, in sport practice particularly, whereby the soft tissue work that's done within practices and the general work that myotherapy does, other than soft tissue, is relevant to these practices and should be a lot more involved than it has been or was. So the specific areas are there, including the stock sales, which is something that we did record because practitioners were given a benefit for achieving stock sales. And then the patient volume gives us measures of what the number of patients were that were seen, because this helped us get our benchmark ratios, which were important to look at in terms of snapshots of performance. And you can see the numbers of patient volume are there. This next one is the example of the bottom side of that spreadsheet. So that's the same spreadsheet, which is this one's now goes on to having clinician hours and total clinician hours for the practices and the total support staff hours. Why do we include this? One of the measures of productivity with any practice is what the cost of your clerical staff is compared to what the billings are of your practitioners. And these are relevant numbers and are benchmarked at a number of different levels depending on the type of practice that people were working in. So the total support staff hours is a measure over the clinician hours, will give you the ratio that's mentioned further down of the support staff hours per hour, which is 0.58. In a multidisciplinary practice, the measure tended to be somewhere around 0.5 to 0.55. In other words, half a administration hour to every clinician hour. In smaller practices, it's often around about 0.4. There are ways in which you can make this staff less, but with quality practices, I think it's important to have clerical staff in the practice. And not only that, to have senior clerical staff that can do some of the jobs that the practice owners have traditionally done themselves, when they should be really outsourcing this to people who are at a lower rate per hour than they are, because they are better off generating fees at a higher dollar amount per hour. So you can see the ratios are quite important. We've got the debtors there as well, which gives people an indication of of what those meant. We actually had a measure for the debtors, which was the days outstanding in the ratios below. We didn't want the measures to be more than 5 days outstanding, so you can see from the spreadsheet that they were below that. The billings per hour was one of the key measures. In fact, the two very fine key measures were the clinician hours per week and the billings per clinician hour per week, because that would give you an indication of the total volume the practice might do, and they really highlighted at a practice-wide and network-wide basis how performance was being measured and how productive it was. We also measured the patients per clinician hours to see what the volume of patients being treated was. You can see it's just under 2, and that's a compilation of different services that take different time points for their treatment. Practitioners treating 2 to 2.5 patients an hour in the day we live in the modern age of therapy is probably about what we can expect. And in multidisciplinary practice, it's different because you've got different time points for all the different consults. Doctors tending to treat 2 to 3 an hour, physios 1.5 to 2 an hour, myotherapists probably around the same as physios, maybe a little bit less, and so on. But the patients per productive support staff hour was also an important measure because we could look at what level of productivity clerical staff are achieving. So again, these have got to be relevant to you or to your practice if that's the case you're working within. The gross revenue per patient was what the average fee per patient was across that network. And in this instance, that will include hydrotherapy classes, Pilates classes, and a number of different other activities that were a lower price point per consult. In a multidisciplinary practice, it would involve sports doctors, physios, podiatrists, myotherapists. You'd expect that to be more like around the $100 gross revenue per patient. Support staff hours I've mentioned, debt days outstanding. And we introduced in red, there's 2 measures there that we introduced to really give us a sense of whether these would be useful measures. The rent per revenue was considered to be very useful because we didn't want it to be a lot more than 10%. That's actually the gross premises cost. And similarly, the revenue per rent per square metre was a relevant matter too, because in larger practices with large clinical and exercise areas, you wanted to make sure you were getting a utilisation of the asset. And I do some consulting with a lot of practices. You've got a large asset and the utilisation is poor. It's good in some areas, but not in others. And really they need to consider what services they might provide out of the particular area. Because if you've got 100 square metres of Pilates and it's costing you $50,000 to rent that large area, to generate $500,000 from Pilates classes is not easy to do. So I think it's very relevant for you to take that into account. The next slide really gives a graphic indication of what the performance has been, and based on the trend in billings, as you can see for the network, where it's up above 200,000, and then it goes light down to the middle of the year. This was a set of data that was collected for weeks of the year, and the first graph at the top is important, but the graphs at the bottom are, to me, more important, because what they give you a sketch of the number of hours, practitioner hours that you're generating. You can clearly see there the top line represents clinician hours. The bottom line in pink represents staff hours. You want those 2 graphs to match each other in terms of the ups and downs, because you don't want to have too many staff at a practice if you haven't got enough clinicians at a practice. So you'd expect the staff to go down when there's less clinicians there, and that was something we managed to achieve in the network quite well. But those ups and downs are an indicator, provided the 2 graphs match one another, then that's what you really want to see. Now, this data was useful for those that didn't like looking at raw numbers. They could get a sketch of what was going on, and they could really look at a quick scan and then go back and compare to the individual practices, or even to the individuals if that's what they needed to do, to see how their performance was going. Again, performance and productivity, very important in corporate areas where the dollars count a lot, but not dissimilar. All practices need to be looking at how they improve their productivity, and that's why we're going about doing these measures. So I've talked a little bit about Achieving Your Career Objectives, the document that we developed, and how we use this as a career planning document. And the method that we used in this document, and I could share this with you, but it's a rather detailed sheet. I've taken the highlights out of this for you. It is something that if you wanted to engage with me at a later time, we could share, because it's a very good planning document and used across many different disciplines with many different practitioners. We found it very useful, and actually developed a document called an A.P.O, Achieving Your Practice Objectives. And then we had a further document called an A.N.O, Achieving Your Network Objectives. And these measures showed alignment between the individuals and the practices and the network, and really gave us a very good amount of data to assist people with. And it wasn't about hitting people with it, it was about helping people improve their performance generally. So the first column of the sheet was called Set Your Objective. And then we looked at the areas of clinical, commercial, risk, and administration, and we created objectives for each of those. So, for example, for each one of these, just to illustrate the point, setting the objective for clinical would be to improve my management of lower limb injuries. Okay, that's a broad objective, but the way we make it very specific and measurable is we talk about what are the methods you could use to achieve that. Well, you could see more patients, yes, because you'd have more experience. You could observe others. You could have others teach you techniques and talk to you about clinical management. We could have others go through case studies with you, that you could go to courses. So all of these things would be methods of achieving that objective. Your KPI for each of those activities might be, well, I said I was going to do 3 courses a year. Did I do 3? No, I only did 2. That's a cross. Did I have my weekly mentoring session with a senior therapist who taught me techniques? Yes, I achieved that every week. That's a tick. Did I do the reading of the articles that were provided for me to read on a weekly basis? Yes or no? What was the number that I achieved? So you ended up with a distinct KPI for each one of those methods to actually file back to what your objective was. And they were the clinical objectives. We wanted to make sure that people understood they were clinical, and then there are other elements of objectives they need to set. So commercial objectives might be about to have a sustainable practice, or even to they may even have said, I want to earn $100,000 a year. Well, that's fine, but what are the methods you need to do that? So you'll need to have a certain number of referrers. So you need to have 10 or a dozen referrers who refer you 5 patients a month to get you 50 referrals a month. You might then need to charge a certain fee. You might need to achieve an average fee of, say, $80. You might need to then actually develop revenue per clinician hour, which is a measure of your volume of $120 per hour. And then that would also tell you how many patients per hour you needed to see. So each of these would be a specific measure to break down that $100,000 number into measurable chunks of what do I need to do each hour to achieve this, and am I doing it? So those commercial objectives would also be about tracking referrers. We developed a document called a referrer tracker, where each person has to identify where the referral came from and what they were doing to interact with that referrer. Had they had a telephone call? Had they sent a letter? Had they gone and visited the referrer? Had they sent something to the referrer? And these all became methods to achieve a certain objective, and then it was measured with the KPI. Administration was included because we wanted practitioners, or we need practitioners generally, to be better organised in how they run and do their administration, which is the writing of files, the making sure they've got the right insurances in place and that they're registered and that they're doing their continuing professional education and that they're not lagging behind and that they're actually spending time to liaise with the practice administration people, so they're talking about what their needs are at the front of the desk. So your administration objective might be to utilise my time weekly to achieve a better organised practice. So your objectives are going to be to put half an hour a week in the diary to do X, to write your file notes up after each patient or at the end of the day, to review what the various activities I need to do with letter writing, etc. are, and to make sure that I tick these off as KPIs. The next area of objective setting was in the area of risk. We'd ask people, what does risk mean to you? They go, oh, well, it means I'm going to get sued. Well, yes, that's a possibility if you don't do the right thing and understand what you need to do and apply inappropriate treatment. But risk starts with you. Are you fit? Are you healthy? Are you well? Moving back to the session we did on balance, do you, on balance, have a healthy diet? Do you do the appropriate amount of physical activity? Do you have good balance? Are you not just working 70 hours a week on your clinical practice and not looking after other elements of your health with social and emotional relationships and spending time with your partner, etc., or children if that's the case? And these are all risks to your health. And if you go down, you can't earn your income. So that's really a very important consideration. And risk also leads into the area of the objective might be make sure I understand what the policies of the practice are and have read them. So then you'd identify you have a practice privacy policy, you have a sexual harassment policy, you have a anti-discrimination policy as examples, and your KPI would be, did I read those? Have I read them? Have I ticked off? Do I understand them? Have I got my registration and my insurance and so on sorted out? That's why we worked on the area of risk. We then had a fifth area, which was around research and education, particularly important for those who are working in clinical practice and with research university-based projects, if that's what they're doing, or an area of study, but it also applied to their ongoing professional education. Were they doing course? Are they doing courses? When are they doing them? What are they doing them on? Are they going to lectures? Are they reading, etc., etc.? So these things would all be put down as methods of achieving. If your education says you wanted to become more proficient with a particular area of study, what are you doing? What is your method to achieve that? How do you measure it? And then the above would be all around 1 year of assessment. Then we'd get people to do a 2-year and a 5-year outcome study, and it would be around what are the methods. They have an objective, and what are the methods? So what are they doing? Like to buy a house in 2 years. What am I doing to achieve that? My method is to save X amount of dollars per week or per month to make a deposit. I'm planning a holiday. I want to go overseas for 3 months within the next 2 years. How am I going to do that? Do I have to then earn extra income in the months that I'm there to achieve a certain amount of savings to do that? And that way we got a sense of where people were in their plan. Their 5-year plan might have been, I'd like to own my own practice. Well, that's fine to say it, but what are the methods I'm going to do in that time frame to achieve that objective? And what else could I be doing? So a lot of the above really comes back to the first of Stephen Covey's 7 habits, which is that of begin with the end in mind, right? Now that's a simple concept, but what it means is even if you're starting out in your practice, where is the end point? Is the end point that you hang up your shingle at 65, exhausted and can't sell your practice? Ideally not. Is your end point you would like to sell half your equity to your fellow practice people that are working there within a certain time frame? Is your endpoint that you'd like to sell out of clinical practice altogether and go and teach or go into another field of endeavour? Begin with the end in mind. And practitioners will say, I don't need to talk about the end, I've just started. Yes, you do. You need to be thinking, what is my endpoint? Because if you begin that way, you're more likely to be focused immediately on what those key objectives are. Okay, the next slide talks about ratios. We talked a little bit about the ratios when we looked at the KPI full document, but you actually look at some of these specific things because they're a little bit easier to see in the larger field. These were the key measures that we decided. Are they the key measures for you? I don't know. I think revenue per clinical hour is important because it is a measure of your productivity in every hour that you achieve. If you look at the hours you work and you look at the fees generated you want to generate per hour, will give you a good indication of your income. Or you could work in reverse. My income I want is this. What fee per hour that I work and how many hours per week do I need to work to generate that fee or to generate that total revenue? And that will really come down to be a product of the patients you see per clinician hour and the revenue per patient. Multiplying those two together will give you the revenue per hour. Patient cost to serve is a measure for management to see how effective the admin staff are being with the cost of what they're doing and how many patients they're processing. Similarly, the staff hours per clinician hour, and I've talked about that before. Estimation of the wages cost as a percentage of billing is important to a practice owner because if the wages costs are 25% or 30% of the total billings, that's not going to leave much to pay the other expenses and even make a margin at the end of the day. So this particular practice, you can see that the patient mix was largely physiotherapy, but these measures can be different. It depends what sort of practice you want to have. As a myotherapist, you want to look at it and say, well, do I want to have other clinicians that are complementary to me? Could I have an exercise physiologist working with me who could do some of the exercise programs or the group classes? Do I study Pilates so that I can do Pilates services as part of my service as a myotherapist? Do I, in fact, have a physio working with me in my rooms? I mentioned before the notion that multidisciplinary allied health practices now without doctors are becoming more prevalent, and doctors are a scarce commodity, particularly in the area of musculoskeletal medicine. So having a balance in your practice of services is myotherapy, physio, osteo, whatever the case may be. They can be complementary. It's very important that you understand whose primary role is what, because you don't want everybody doing the same thing, because all it does is create confusion for patients. So do keep that in mind when you're looking to set up your practice with other disciplines in there as well. Some of the practice benchmarks that we used to look at in the practices, and I think these are useful for any practice owner to do, and in a myotherapy practice, I suspect they're probably going to be in some ways similar, but they may not be. But these are the areas you really would want to look at with your benchmarks. So when you look at your P&L, you can look and say, okay, well, my staff costs were 27%. Whoa, that's obviously too much. The premises I'm in is costing me $80,000 a year and I'm generating $300,000. Well, that's not going to leave you with a benchmark of 10% of your total costs being through rent. So have I got the right premise, or do I need to bring other practitioners in as contractors or consultants, or do I need to rent some of my space out? Generally, the often mistake people make is they don't look at the asset utilisation, which I mentioned it a little bit before when we talked about rent per square metre of revenue that's generated. Practitioners in a multidisciplinary practice will cost somewhere between 50 and 55%. Doctors get paid more generally, and therefore, and physios less, podiatrists in the middle, myotherapists a little bit higher than physios as well, because they generally see less patients per hour than physios, but that is a benchmark figure across all disciplines. G&A means general administration expenses like stationery and banking and some of those other related expenses. And with premises, I'm including in premises, by the way, some of your expenses like electricity and so on and so forth. IT and tech is probably higher in that area there, and digital marketing, and marketing may be a bit more with traditional digital marketing than 2.5%. Other is your general other expenses, with you giving a margin at the end. We tended not to worry too much about an individual expense that was less than 1% of the total expenses, because managing those, you'd really be managing the ones that are greater, and at the end of the day, the three that make the biggest difference are those that are the three items that are in bold: staff, premises and practitioners are the three that make up the bulk of the expenses. You can see of around 70% of the total cost. So they're the ones you need to look at the most carefully. Referrers. Obviously, it's very important to understand referrers, not just the need for referrers, but to understand referrers. And I was taught some years ago that one of the ways to look at how you might doing that was to actually identify if there were any risks for someone to refer to you. And that might sound a bit odd, but at the end of the day, risks are something you need to mitigate, and then you need to sell what the benefit is of seeing you. And a risk, we'll go into this in a bit more detail, but a risk might simply be it's risky for me to send a patient to another practitioner because I might lose the patient. That's what I mean by risks. Or the therapist might do a bad job with the patient and they might come back and complain to me. They're risks. Benefits are what you can offer that negate those risks. So that's what you need to do in the terms of selling the benefit to the referrer. And also remember that the WIFM principle applies. WIFM simply being what's in it for me. And that applies to not just you, but to any person who refers to you, even if they don't say it. We happen to know why GPs love referring to imaging, because there was a survey done of GPs about their various referral habits and why they liked referring to specific groups. And they always liked referring to imaging because they got a timely result. They would get a result quite quickly. It was generally not much more than 24 hours before they had a result. They would always receive a report, a written report, so they didn't need to read the scans or the imaging or the ultrasounds. They could get a report that they would then discuss with the patient. And they also mitigated their risk. So one of the risks that someone has in referring to you is that they think they may not know the diagnosis. And the risk is they could look like an idiot by actually referring the patient to you or someone else and getting the wrong result. So rather than saying, look, Joe, I think you've sprained your ankle, you might have a fracture, I don't know, I'll send you for imaging, and then I've cleared that risk, which is one of the reasons that GPs do that so readily for imaging. So just to talk briefly about the benefits of an allied health referral for a GP referrer, is that often a GP, by referring to a allied health professional or anyone referring, is that they hopefully will get a diagnosis with sound clinical reasoning. So therefore, that's something you might emphasise, that you will make a diagnosis and you'll use appropriate processes to reason for that result. You'll get an improved outcome. The patient will improve more quickly than if they're not having treatment. And what that leads to is the GP having a greater status in the eyes of the patient. It's often been said, and I think this is very true, a good referral is almost as good as a good treatment, because you will get benefit from a good referral, even if it's you saying, I'm not sure what's going on with you, rather than treating somebody 20 times after a couple of visits, or we used to use 3 visits as the measure. After 3 visits, if a patient's not improving, then they need to see somebody else for an opinion. Because otherwise, you will lose goodwill if you continue to treatment and they're not improving. Because if they're not improving, it may be you've got the wrong diagnosis or your treatment isn't going to be efficacious. There's a certain amount of loyalty that's gained from getting that benefit. In other words, the physiotherapy or the myotherapy practice may well refer patients back, and that comes back to the cross-referral idea as well. And in care planning, not all disciplines have got care planning, but care planning is an area where there can be mutuality between doctors and the people they refer to. And not only that, and I've seen that many times, it's a support network or a social network, even a friendship network for referrers with those they refer to. And I can think of legion examples of people who developed social relationships with their referrers, be it a GP or a specialist or a sports club or the president of a club, etc., etc. Those things can become genuine relationships where there's mutual support based on a common goal or outcome of wanting to see improvement with a patient, for example. Now, rather than put the risks first, I decided to put the benefits first, because I think some of these elements are negated by the benefits, as I said before. But I mentioned the idea of the risk for a GP with an allied health referral is that the GP will look like an idiot. Why? Because the diagnosis the GP made for a musculoskeletal problem will be changed or denied or whatever by the referrer. And the one way to mitigate this is to make sure that you don't say to the patient, oh, well, the GP's wrong, I'm going to treat you for this. And then the patient goes back to the GP and says to the GP, oh, you didn't get the right diagnosis, they treated me for this. So the better way to handle that would be to contact the GP or contact the referrer and say, look, I'm not sure that your daughter, if it's a family member, or if it's a team coach, or if it's the school nurse, or it's the GP for that matter, to say, I'm not sure of the diagnosis. I'm considering that there may be a more severe problem. Are you happy for me to refer them to imaging or another practitioner, or would you like to review them? That's a really important way to deal with that. As soon as the patient leaves the referrer's bench, there's a loss of control. They don't know what's going to happen. They don't know what's going to happen to the patient's treatment. They don't know whether the patient's going to get treatment. There's a risk associated with lack of control. And that's why that's negated very readily by coming back to the practice and saying, we will let you know the same day how we got on with that patient. That's why we often encourage people to reply to a referral by letter or by phone or by fax or by text message or whatever it is on the same day. They may lose the patient. The patient might decide that they're not going back to that practice that referred them. They lose revenue because rather than seeing them, they're seeing the person they referred them to. There's a poor response to treatment, which is a risk I mentioned. We need to actually make sure that we negate that risk by selling the benefit that if a patient's not improving, we will refer them back. That negates the risk. That is selling the benefit of them seeing you. And also, make your fees transparent. There's a risk because the patient might go, oh, you sent me to the physio or the myotherapist, they charged me a fortune and saw me 20 times. So that's a negative association. So don't get caught. Make sure it's transparent so the GP can say, this is what it costs if you see Mary the myo or Paul the physio or whatever it might be. Informing them what your fees are is something you should definitely do. So otherwise you don't want to develop that negative association with the fees otherwise that can be there. So have a really good think about that. If you identify the risk, you've got to then identify the benefit and you've got to sell the benefit. Selling the benefit doesn't mean sitting in your chair in your rooms. It means communication, either by phone or by text message or by digital message or by whatever mechanism you find. GPs particularly tend to be fairly traditional, so a letter still works, but it could be find out what their email address is if you can. That's a difficult thing to do. They don't readily give it out. Find out what the best communication channel is for those that are referring to you so you can get prompt communication back to them. These are all very important things. Then you've got to review performance. You've got to review what you've done. Now that really is about having appropriate KPIs and the measures for that. But it's also about getting feedback from those you work with. Encourage people to give you feedback. Oh, I heard what happened with that patient. You did a really good job. Or get the receptionist to tell you what the patients might have said about the consult, whether they thought it was good or whether they enjoyed being with you. Now, one measure will be you'll get busier, but another one is that feedback from people, and get the feedback quickly. Ask your superior, how did I go? What do you think? Rather than waiting for feedback several months later. It doesn't work. Similarly, if there's bad behaviour, that's about feedback too that relates to the behaviour at the time that it happened. Getting your mentor, if you've got one, to assess your performance with you quarterly is a good idea. And make sure you've got what the measures are going to be based around the performance so that you can look at them with your mentor and they can advise you about how you could do better. And finally, get someone to help you be reviewed annually. It might be one of your partners if you've got a practice. It might be your superior. If it's not that, it might be a peer. But someone that sits with you and looks at your performance objectively rather than you looking at it subjectively. One measure will be how you've performed commercially in that 12 months, but it might also be that how you develop relationships or how you were in the practice or how you were seen as a confident, enthusiastic person. Did you go to all the learning opportunities that were available for you? Did you plan your time well? Did you actually meet the commitments that you said that you were going to do? These are all ways that someone can help you with that external review. Levels of initiative. The reason I relate this to you is for you to actually think about your level of initiative with your mentor. Think about your level of initiative, not just even with a referrer, the level of initiative you show with a referrer, the level of initiative that the practice take towards you. And I really start with the lowest level of initiative is that wait until told. And a good example to illustrate this to you is a commencing work experience student who often will start with you and they'll sit there in the corner and they'll wait until you tell them to do something. Now that's because they're fearful, it's because they don't understand what's involved, and that's like anything about communication. How do you then communicate what you want them to do? It's about clarifying expectations. So clarifying expectations will help with a level of initiative. So make sure, would you like me to do this? Is an ask. So that's what you'd expect of an allied health student on a placement who comes to you and says, look, I'm starting with you. Are you happy for me to ask you what things you want me to do? Some of this can be dealt with even before they start with you by actually identifying right up front, this is what you expect. So with you coming to have a placement at this practice, I'm not going to be giving you constant instruction. And similarly with a patient. With a patient, feel free to ask any questions. You may even have your own thoughts about some of the things you could do. I'm more than happy for you to recommend, which is the next level of initiative. And that's what you expect from a final year student. A student saying, oh, we've learned at school that you should do blah, blah, blah. Do you recommend that that's something that you do or I do or I should get the patient to do? So recommending is the next step along that process of showing initiative and being very proactive, doing it and reporting immediately. So again, if you've got somebody working with you or for you and they're actually taking action themselves and saying, oh, well, just letting you know that I went and sent the letters out to the GP. Or in your case, you go to the mentor, just letting you know that I've decided now to go and observe so-and-so. I rang them up and I'm now doing it because it fits in with the recommendations that you made. So I've gone and done it and I'm letting you know. Consequently, down the track, that would be something that would happen that you would do, and then you would report to your supervisor or your mentor or your practice manager, or whoever it might be, that you are actually doing these activities and you're reporting every 3, 6, 12 months. Every time you have a review, you'd report on the things you've been doing. That's a higher level. And then after a period of time in clinical practice and having run networks of practices, you identify self-driven, motivated, productive people who just go out and do it. This tends to happen in practices where they're able to do it, they're comfortable to do it, they're not curtailed in what they want to do, and they're free to take the initiative. But think about where you are in a whole range of things here, because even with a referrer that comes to you, you don't wait until they tell you, you ask or you recommend. You're proactive with them. That's one of the habits that we'll talk about when we talk about our next session, which will be about growth and how you can be more proactive in the way you develop and grow your practice. So that pretty much completes presentation 3, measuring productivity and setting objectives. I think there's a lot of material there that could be of interest to you. And the next session, when we cover growing your practice, I think some of the rubber will hit the road and you'll be able to see how this can really work for you to make yourself have a more successful practice and a more productive practice. Thanks for joining me today, and feel free to follow up my website at michaelkenihan.com.au or to join me on LinkedIn.